Hello guys, welcome to the Docsaab's diary. Today we are really getting into a vital topic, one that affects millions globally but is often well misunderstood, is the dengue. Dengue is just so common in many places, understanding it beyond just mosquitoes. It is a really key. This should give you that practical sort of multi-layered view. Let's picture this. You are a clinician, maybe in India, someone comes with a fever. How do you even start thinking? Could this be dengue? What are those first steps?
Well, it usually starts with what we call a presumptive diagnosis. We look at two main things. Has the patient been in a dengue endemic area in the last 14 days, or do they have a fever? Plus at least two typical symptoms like nausea, vomiting, rash, really a bad headache, pain behind the eyes, muscle pain, joint pain. That combination get dengue on a radar.
Okay, so that's the initial flag. But reading through the guidelines, what really jumped out at me was the focus on warning signs.
Absolutely, those warning signs are critical. Their presence fundamentally changes everything. How we manage the patient, what are we looking for, specifically intense abdominal pain or pain when you actually press on the abdomen. This can mean plasma leakage into belly, which is a big step towards shock. It's serious. Then persistent like 3 or more time in just 1 hour or maybe 4 or more over 6 hours. It's not just about losing fluid, it signals a major problem with fluid balance. We also look for visible fluid accumulation that could be fluid around the lungs, that is pleural effusion, or in the abdomen called the side around the heart, that is pericardial effusion, or any sign that plasma is leaking out of blood vessel where it shouldn't be. Other really crucial ones like any bleeding from mucosal surfaces, gums, nose, even unusual vaginal bleeding or visible blood in the urine. Changes in mental state is also a big red flag like sudden irritability or become really drowsy, scoring low on GCS. And a large liver, what we call hepatomegaly, is another sign, specifically if it is palpable 2 centimeter or more below the ribs. And finally, a progressive increase in the hematocrit. If we see that hematocrit climbing in two checks, maybe 6 hours apart, it strongly suggests that fluid is leaking out of bloodstream, making the blood more concentrated. It's a key indicator of that plasma leakage.
Wow, okay, that's quite a list. Some sound obvious, others may be less so. So, once you suspect dengue, and especially if these warning signs pop up, how does that dictate the next step? Like, who needs hospital care versus who can maybe manage at home?
Yeah, that is the core of triage process. We basically group patients into three categories A, B, and C. Group A is for outpatient management. These are folks with dengue but crucially no warning sign. They do not have any serious underlying health conditions or no social risk factor that would make home care difficult, like living very far from a clinic or living alone. They still need close follow up, daily checkup for dehydration, any emerging warning signs, and watching for when the fever breaks, what we call deference.
Got it. Okay. Let's shift gears slightly for patients who are managing at home or for anyone wanting to be prepared. What are the recommendations for managing symptoms like fever, staying hydrated, and importantly, preventing the spread within a household?
Right, for home care, fever control, acetaminophen or paracetamol is the way to go. You can give it up to 4 times a day, usually every 6 hours if there is fever. Tepid sponging using lukewarm water on the skin can also help to bring the temperature down. And what is the absolute no for fever? Absolutely no brufen, no aspirin or any other NSAIDs. They can increase the risk of bleeding in dengue, which is really a concern. So stick strictly to acetaminophen. Now preventing dehydration is all. High fever, vomiting may not feel like eating or drinking. It's easy to get dehydrated. So encourage plenty of fluid. Water is good, but also things like ORS, fruit juice without much sugar, coconut helps.
And and how do you know if dehydration getting serious? What are the signs to watch for?
Look for decreased urination, few wet diapers or babies, or just not going to the bathroom, less tears when crying, dry mouth, tongue or lip, sunken eyes, or in infant, a sudden fentanyl on their head. Behavior changes to being unusually listless or sleepy or sometimes agitated or confused. Physically, a fast heartbeat or hands and feet feeling cold or clammy, any of those signs mean severe dehydration, and you need to get to a clinic or emergency room right away.
And preventing spread within the house since mosquitoes transmit it.
Yes, crucial point. The person who is sick should really rest under a mosquito bed net even during the day because the mosquito that spread dengue bite during the day. Everyone else in the household should use an EPA registered insect repellent and tackle a source mosquito breeding site like MD and scrub any container holding water, flower pot, saucers, bucket, old tires, pet water bowls at least weekly. Make sure windows and doors have screens if possible and keep them in good repair.
So it's about protecting the patient from being bitten again, protecting others, and reducing mosquitoes overall.
Exactly, it breaks the transmission cycle within the home.
Because it's so important, even if the fever is improving, what are those urgent signs that mean stop home care and go to the ER immediately?
Absolutely vital to return immediately if any of these appear, like severe abdominal pain or persistent vomiting, any signs of bleeding, nosebleed, bleeding cum, vomiting, blood in the stool, which might look black and terry or unusual, heavy vaginal bleeding, also becoming very drowsy, difficult to wake up, or usually irritable, having pale, cold, clammy skin, or any breathing difficulty. These all are emergency sign indicating potential progression to severe dengue. Don't wait.
Then Group B requires going into the hospital. This includes anyone who shows any of those warning signs we just listed, or even without warning signs if they have the other issues like pregnancy, kidney problems, bleeding disorders, shortness of breath, or if they just can't keep fluids down. So warning signs or are these other risk factors land you in Group B needing inpatient care.
That also include patients with significant pre-existing conditions or those social risk factor. That sure coexisting condition could be things like high blood pressure, diabetes, asthma, chronic kidney or liver disease, maybe a history of peptic ulcer, or even just having a high BMI. Being on anticoagulant therapy, blood thinners is another one. So the social risks are more important too. We think about age, babies under 1 year or adult over 65 living alone is a big one, or not having reliable transport to get back to the clinic quickly if needed. Things like unstable housing or significant poverty can also make safe home management really challenging. Basically, anything that might prevent someone from getting help fast if they deteriorate.
What about Group C? Group C is also inpatient but is for the most severe cases. These are patients already showing signs of severe dengue like shock, where the circulatory system is failing, or severe respiratory distress because of all that plasma leakage. Right? It also includes patients with clinically significant bleeding or severe organ damage, things like myocarditis or severe hepatitis with liver enzymes sky high over 1000 or even encephalitis. These patients need intensive care. Now, for those who do not need hospitalization, who need hospitalization, those Group B and C patient, can we dive a bit deeper into the inpatient management, particularly around fluids? How does the body's response in dengue make fluid management so central?
It's central because the main problem in severe dengue is that plasma leakage. Fluid shift out of the blood vessel leading to dehydration within the vascular system, but potentially fluid overload in other body compartment like lungs or abdomen. So IV fluid therapy is about carefully replacing lost intravascular volume without tipping over into overload.
How does that typically start for, say, a Group B patient who need fluids?
Patients needing IV fluid but not in shock, we often start with the isotonic crystalloid like normal saline or ringer lactate, maybe at a rate of 5 to 7 ml per kg per body weight for 1 to 2 hours. Then we assess and adjust based on clinical improvement and urine output at least 0.5 ml per kg per hour and a hematocrit if the patient is improving. Urine output is good and hematocrit is stable or start to fall indicating rehydration. We can gradually reduce the fluid rate maybe down to 3 to 5 ml per kg per hour, then 2 to 4 ml per kg per hour. The goal is to use the lowest rate that maintain good perfusion in urine output and stop IV fluid as soon as the patient can drink adequately and critical phase of leakage is over.
And for the group C patient, those presenting in shock, that's an emergency for shock.
The initial approach is rapid resuscitation with isotonic crystalloid. We can give a bolus a large volume quickly, typically 20 ml per kg over just 15 to 30 minutes. Then we immediately reassess vital sign, capillary refill, mental status. If that first bolus is not enough, if the patient is still in shock, we can repeat the crystalloid bolus maybe once or twice more. But if after 2 or 3 crystalloid bolus the patient is still unstable and the hematocrit is high or rising, that suggests ongoing severe plasma leakage. That is when we consider switching to a colloid solution like albumin.
Now, if shock persists, despite these measures, the patient needs intensive care. We will be thinking about things like vasopressors, and we will be urgently looking for other complications like severe metabolic acidosis or importantly hidden bleeding, occult hemorrhages. It really highlights how specific dengue management is. Okay, that makes sense. Let's talk about those crucial do's and don'ts. Let's start with don'ts because some of these go against common practice in other areas. First, don't use corticosteroids routinely like prednisolone. There is no good evidence they help in danger and they might actually increase the risk of gastrointestinal bleeding, raise blood sugar, and suppress the immune system. So, generally avoid them. Second big don't measure prophylactic platelet transfusion or even transfusing just because the platelet count is low. But studies shows that transfusing them usually doesn't prevent severe bleeding. It does, but transfusion platelets carries the risk like fluid overload and it can actually prolong the household stay without clear benefit in most cases. So we reserve it for very specific situation, not just low numbers. Third, don't dank giving half normal saline, that's 4.45% saline as IV fluid. It's hypotonically less salty than blood, so it tends to leak out of the blood vessels faster and can actually worsen that fluid accumulation in the lungs or abdomen. The infusion stick to isotonic fluids like normal saline or ringer lactate. Okay, so the type of IV fluid really matters immensely. And the fourth don't related to that is don't assume everyone needs heavy fluids. Always check if the patient can drink adequately. First, oral rehydration is preferred if possible. If IV fluids are needed, the goal is to use the minimum amount necessary to maintain good circulation, good perfusion. Too much fluid can be just as dangerous as too little. Okay, so those are some major things to avoid. What about the proactive things, the essential do's that really make a difference?
On the do side, first do make sure outpatient group A know exactly when to come back for follow-up and crucially teach them and their family about the warning signs and about the critical phase they need to know what to watch for.
And that critical phase you mentioned, it starts when the fever breaks.
Yes, this is probably the single most important thing to do. Do recognize the critical phase. It typically start around the time when the fever break to drop, what we call deference. This might feel like getting better, but it's actually the period usually lasting 24 to 48 hours when plasma leakage peaks and patient can rapidly develop shock. It's a period of high alert.
So recovery starts, but the danger increases. That's the key.
Absolutely key. Next, do closely monitor everything fluid intake, urine output, vital sign, heart rate, blood pressure, pulse pressure, hematocrit level. Frequent careful monitoring lets you catch deterioration early, which can lead to the next. Do recognize and treat early shock. We call it compensated shock. The blood pressure might still be technically normal, but you see other signs that the pulse pressure, narrowing the gap between the top and bottom BP, numbers shrinking to less than 20 mmHg, heart rate climbing, maybe the hands and feet feeling cool or slow capillary refill. Catching shock at this stage is crucial before the blood pressure actually drop. Exactly once the blood pressure drop, that is hypotensive shock and it's much harder to reverse. Next, do if the patient is in shock and not responding to initial rapid IV fluid bolus, say 2 or 3 tries with isotonic crystalloid like saline, do administer colloid. These are thicker fluid like albumin but tend to stay in blood vessel better. And finally, do give packed red blood cell or whole blood promptly if there is clinically significant bleeding. If the patient is bleeding obviously or their vital signs are unstable and hematocrit is dropping despite fluid resuscitation, do not wait. Transfuse blood.
So, pulling back a bit, we talk about who needs hospitalization, how do clinicians then decide when it's safe for someone to go home, and can we just recap the nuisance of choosing which fluids, oral or IV, and why sure deciding on hospitalization. And getting discharged, what are the criteria for going home? Discharge requires clear improvement and stability. Key criteria usually include being fever free for at least 48 hours without needing fever reducing drugs like acetaminophen. Appetite should be improving. Vital sign must be stable. Urine output needs to be adequate. There should be no signs of respiratory distress or ongoing significant bleeding. And importantly, on the left side, the platelet count should show a clear upward trend and the hematocrit must be stable without the patient needing ongoing IV fluids. They have to be stable on their own. That seems pretty comprehensive.
Now about the fluid themselves. Oral fluid first always preferred if the patient can tolerate them and is not in shock or showing severe warning sign. The amount needed varies, but as a baseline, adult may need around 30 to 35 ml per kg per day, maybe a bit less for older adult. Kids need more related to their size, often estimated using formula, but need increased fourth fever, vomiting, diarrhea, or even just sweating, they all increase fluid loss. So intake need to go up to compensate. Oral rehydration solutions are great because they have electrolyte too, not just water. And when IV fluid are needed, the choice between say ringer lactate and normal saline, both are isotonic crystalloid. First choice is RN. RL is often preferred as it is more balanced, closer to plasma composition, and is less likely to cause acidosis compared to large volume of normal saline. However, you might be cautious with RL if someone has severe liver failure or low sodium and normal saline 0.9% NaCl is widely used. Its main drawback is its high chloride content which can worsen or cause metabolic acidosis if large volume are given. So it may be avoided if someone already has high chloride level or severe acidosis. Colloids like albumin are generally reserved for that refractory shock scenario we discussed when crystalloid alone are not enough, especially if the hematocrit is high. Choice that depend on local availability and cost. And remember with the specific caution with dextrin solution as they can interfere with clotting and potentially worsen bleeding.
Okay, what about just maintenance fluids? Keeping someone hydrated intravenously if they can't drink.
For maintenance IV fluid, we often use formula like the holiday sugar method, which calculate a rate based on body weight. But these are just starting point, always adjusted based on patient's clinical status, hydration level, urine output, and any ongoing loss. A lower rate may be needed in patients at risk of fluid overload, like the elderly or those with heart failure. This constant assessment, especially looking for shock, seems critical.
What if the shock is clearly due to bleeding, hemorrhagic shock?
If there is evidence of significant hemorrhage causing the shock, like a rapidly dropping hematocrit despite fluid or obvious major bleeding, then the treatment is blood transfusion, typically packed red blood cells.
And what about platelets or plasma in that situation for hemorrhagic shock?
Interestingly, even in hemorrhagic shock due to dengue, routine transmission of platelet or fresh frozen plasma is generally not recommended unless there is a specific coexisting reason or massive transfusion protocol being followed. The primary treatment for hemorrhagic shock is stop the bleeding if possible and replace lost red blood cells.
Can you walk us through how clinicians assess the stages of shock? Physiologically, it feels like reading the body signals.
It absolutely is like reading signal. We look at a constellation of signs to differentiate between stable circulation, compensated shock, where the body is trying to maintain blood pressure, and hypertensive shock, where the body is failing.
Okay, think about that. Is the patient alert and clear, or are they becoming restless, agitated, confused, or lethargic? That's a bad sign. Capillary refill time, press on a fingernail of the skin. Does the color return almost instantly, brisk 2 seconds, or is it slow, prolonged 2 seconds? Very prolonged refill or molded skin suggest poor perfusion. Extremities, the hands and feet are warm and pink, or are they cool to the touch or even cold and clammy? Cool peripheries indicate blood is being shunted away from the skin to vital organs.
Can you feel a good strong pulse in the wrist or foot, or is it really weak or thready, maybe even absent? Heart rate usually increase in shock as the body try to compensate. Very late shock might even cause a slow heart rate, bradycardia. Blood pressure in compensated shock, the systolic might be normal, but the pulse pressure often less than 20 mmHg. Hypotensive shock is when the systolic pressure itself drops below the expected level for age and breathing. Respiratory rate often increases as the body tries to get more oxygen or blow off acid. Very deep rapid breathing, small breathing can indicate severe acidosis. Urine output is a greater indicator of kidney perfusion. It starts to decrease in compensated shock and can become very low oliguria or stop altogether.
It really underscores the need for close monitoring. Okay, we have gone incredibly deep on dengue itself, but one challenge, especially in endemic areas, is that other fevers can look similar initially. Zika, chikungunya. How do clinicians try and tell them apart when a patient first presents? It seems like a bit of medical detective game.
It can especially early on when symptoms might overlap. But there are patterns clinicians look for high certainty. Dengue is often strongly suspected by a combination of low platelet, rising hematocrit, and low white blood count. Chikungunya, on the other hand, characteristically causes very severe joint pain, often debilitating arthralgia and sometimes intense itching. Zika frequently present with a prominent rash and conjunctivitis.
So, those are the stronger signals. What about less certain clues?
With moderate certainty, things like significant vomiting, bad abdominal pain, or bleeding might lean toward dengue. A rash or muscle pain could be chikungunya, though dengue can also have them too. But again, that combo of rash plus conjunctivitis point more towards Zika. And some symptoms have low certainty for differentiation. Things like headache, pain behind the eyes, that is retroorbital pain, or even mildly elevated liver enzyme can be seen in all three. So they are not very helpful in telling them apart even on early without specific lab test.
It really highlights the importance of considering the whole clinical picture and eventually specific diagnostic test exactly.
Clinical suspicions guide initial assessment, but definitive diagnosis often require lab confirmation, especially when these viruses co-circulate.
Well, this has been an incredibly thorough journey. We have gone from those first subtle clues of dengue through the critical warning signs, how patients are categorized for care, the really crucial do's and don'ts, some quite thought right into the fine details of fluid management for inpatients, and how to assess shock plus home care, prevention, and distinguishing it from similar illness. I feel like we have really distilled a huge amount of vital information. And guys, thank you for watching this video, and please like, share and subscribe to the Docsaab's Diary.